Let's walk through the basic approach to hyponatremia. Hyponatremia is typically defined as a serum sodium less than 135 milliequivalents per liter. Severe symptoms include confusion, ataxia, seizure, and patients can present comatose. Milder presentations include headache, lethargy, and presyncope. Your first step to assessing hyponatremia is determining the serum osmolality. Recall from chemistry and organic chemistry that osmolality refers to the number of osmoles of solute per kilogram of solvent. So think about all those electrolytes and components in the serum. A normal human osmolality is 275 to approximately 285. And depending on the hydration status or the overall water status, the extracellular fluid and intracellular fluid compartments at the cellular level are also affected. Water follows salt, so if someone is very dehydrated, then the osmolality of the blood increases, signaling the body to secrete something called antidiuretic hormone, or ADH. This acts on multiple receptors, although primarily at the kidney, to increase overall water reabsorption. With that being said, determine your serum osmoles. The normal serum osmoles is approximately 280 to 285, and this portends to an isotonic hyponatremia. Look out for hyperproteinuria or hyperlipidemia. Hypertonic hyponatremia, as depicted on the far right, has a serum osmoles greater than 285. Assess for hyperglycemic states, mannitol or sorbitol use. Low serum osmoles, including less than 280, and this is your hypotonic hyponatremia. We will dive into this a little deeper, but for now, step 1, assess the serum osmoles, and step 2, assess the volume status. I would argue all hyponatremic patients, regardless of etiology, need to be volume resuscitated. Remember that at the cellular level, this is not a disorder of sodium, but rather water. When you have hypotonic hyponatremia, remember a serum osmol less than 280, you need to assess the volume status. Pay attention to clinical signs such as mucous membranes, skin turgor, peripheral swelling, and or edema. Once you have determined their volume status, you will start looking at urine osmoles and urine sodium levels. Hypovolemic hyponatremia has a total decrease in total body water and sodium levels. When the urine sodium is greater than 20 milliequivalents, this is suggestive of renal losses, either from diuretics or mineralocorticoid deficiency. The treatment is isotonic saline. When the urine sodium is less than 20 milliequivalents, the hypovolemic state is due to extrarenal loss, such as diarrhea, MSS, third spacing, or bowel obstruction. Treatment includes isotonic saline. Euvolemic hyponatremia is where there is an increase in the total body of water with normal total body sodium levels. The urine sodium will be greater than 20. Next, assess the urine osmolality. If it is greater than 100, think about SIADH, hypothyroidism, adrenal insufficiency. Treatment includes fluid restriction. When the urine osmolality is less than 100, this is often seen with primary polydipsia, low salt intake state, such as beer potomania syndrome. Treatment and management includes fluid restriction. Hypervolemic hyponatremia has an increased total body water. When the urine sodium is less than 20 milliequivalents, the etiology is likely heart failure, cirrhosis, nephrosis, or hypoalbuminemia. Treatment includes diuresis, fluid, and sodium restriction. When the sodium is greater than 20 milliequivalents, the etiology is often due to renal failure. Treatment is fluid and sodium restriction and dialysis. Here we defined hyponatremia, reviewed classification of hyponatremia and diagnostic criteria for hypovolemic, euvolemic, and hypervolemic hyponatremia, and briefly reviewed management and treatment. Please comment with questions, and thank you again so much for your time.